Hi class, we are talking about brain disorders in chapter 23 of neurology. I'm on page 524 in chapter 23. And in this chapter, it covers seizures, brain tumors, strokes, what to do to help someone who has a seizure, which is always going to be on your NCLEX. I'm sure when you've been practicing, you've been seeing it in many test questions. But keep in mind to cover status epilepticus, seizures, and safety issues for seizures. So when we're looking at page 524 in your med-surg book, we see that there's many different types or many different reasons for a seizure. Brain trauma can cause seizures, head injuries, strokes, metabolic diseases can cause seizures, low blood sugar. There's a lot of different reasons. And if the condition that is causing the seizure cannot be found, then they will say possibly that the patient has epilepsy. If they've corrected everything that's known to be corrected, whether it's in the patient's electrolytes or controlled what's going on with the growth in the brain or something like that, control the blood sugar, and there's still seizures, then it could be that there is epilepsy diagnosis, or it may be idiopathic. There's no known reason at all why the patient has seizures. But anyway, 3 million children and adults are diagnosed with epilepsy. But seizures in general are diagnosed by an EEG and an MRI, so review both of those tests and preparing your patient for those. Also, read through your different types of seizures, partial seizures versus generalized. Partial seizures are also called simple seizures or focal or temporal because that is the area of the brain where they originate. And partial seizures are typically unilateral, only affecting one side of the body and one side of the brain. Also, with a simple partial seizure, the patient doesn't lose consciousness. Also, with a complex partial seizure, there is some loss of consciousness, and a patient can also have what's called automatisms, which is a repetitive action such as chewing, picking, smacking, just like I did, and so that's called an automism. Also with generalized seizures, when you think of a seizure as a patient jerking, that is what is considered a generalized seizure. They can be tonic, clonic, or tonic-clonic, and in a tonic seizure, you think of rigidity. And in a clonic seizure, you think of the arms and legs jerking rhythmically. In a tonic seizure, when the patient stiffens, the muscles that even help them to breathe can stiffen, so they could not be breathing properly. And then in a clonic seizure, they're going to have shallow breathing. The patient is going to have bilateral symmetric movement on both sides of the body and more than likely lose consciousness. An atonic seizure is when the patient has what's called a drop attack type of seizure. There is generally no aura with a generalized seizure. When I mention the word aura, it can be an auditory aura that's going on or visual. The patient can see spots, floating dots. Part of the vision is blacked out. They can also have auditory auras, which is hearing certain things. They can even have a sense of smelling something. I know a young man once who had a brain tumor, and he was having an aura of smelling glue prior to having a seizure. So he was having an aura of the sense of smell. And also, I mentioned looking through status epilepticus. That is when there is a seizure that's been going on for about 5 to 10 minutes. It's prolonged partial or generalized seizure with recovery between the attacks, which is very brief. Or it can be a rapid, unrelenting series of convulsive seizures without intervening periods of consciousness and an absence of respiration. Irreversible brain damage can occur if the seizures are not controlled. So obviously this is an emergency situation called status epilepticus. If the patient is hospitalized, We'll talk about safety in just a moment, but we're going to make sure that the patient has oxygen in place if it's in the room to apply. Make sure that you are watching out for the patient's safety and going by doctor's orders as far as administering something to help stop the seizure. Many people who are suffering from seizures, they have an order for them to have what's called Diastat Acudile. And it's a rectal diazepam or a rectal Valium that works in about 15 minutes after it's administered. So if someone is in status epilepticus or is having a long seizure and they have a doctor's order to administer this after 5 minutes or 10 minutes, whatever the doctor's order is, then it has a lubricant on the end. It's like a bulb dose of medication, and it's administered rectally. I will find a video for you to watch on that. There's a video on YouTube for rectal Diastat administration, and that would be very good for you to watch and be able to answer questions about. Like I said, this is by doctor's orders. They will have a protocol to go by if the patient's having a seizure longer than 5 minutes or 10 minutes, and it takes it about 15 minutes to work. So as far as a diagnosis of epilepsy, you're looking at the patient's history, actual signs and symptoms. So when someone does have a seizure and you're in their presence, or let's say a family member's in their presence, they need to document as much as they can about the seizure and how the patient is behaving. We'll go over more of that in just a second. And EEG and MRI will help determine the location in the brain of the seizure, which will help determine the type of seizure it is. Also, with diagnosis of epilepsy, we're going to look at electrolyte imbalances also with the patient. During a seizure, neurons involved have a low threshold for excitation. Okay, so neurons involved have a low threshold for excitation. And in epilepsy, abnormal electrical activity is present in the brain. And remember, our partial seizures are unilateral, generalized seizures are bilateral. So in controlling epilepsy, we want to control or eliminate the cause, administer anti-epileptic drugs as prescribed in patient teaching. When you are teaching a patient or a parent of a patient about taking their medication for epilepsy or for seizures, then they need to be sure and take it regularly. It can be very harmful to the patient if they skip doses. Also, if they're not taking good care of themselves. They need to eat properly, they need to get enough sleep, and try not to be under a lot of stress, because that can emotionally cause a patient to be more at risk for a seizure, or if their body's stressed by not having enough rest, having enough nutrients in their body, that can be more apt to have a seizure. A ketogenic diet is used sometimes for those with epilepsy. Increased fat and protein in the diet has been shown to decrease seizure activity. Also, there's something called a vagal nerve stimulator. That's an implant that's been shown to help those who have epilepsy with decrease in seizures. We mentioned treatment of the patient with status epilepticus. Care is focused on supporting vital signs and preventing injury. Respiratory support needs to be given, and the patient could even be a candidate for intubation. I would like for you to look at on page 527 in the middle of the book. Let's see if I can show this to you. Nope. Okay. Maybe if I do this. Okay. If you're looking at page 527, clinical cues on this page, in the middle of the page, it talks about the, in the purple box, when IV phenytoin or dilantin is administered, needs to be mixed in 0.9% saline solution and flush the line before and after administration if a glucose IV solution is running. Never administer IV Dilantin faster than 50 milligrams a minute because of the risk of cardiac dysrhythmia, hypotension, or bradycardia. Also, on page 528, please read through the section on administering IV Dilantin to a patient who has a feeding tube. It needs to be stopped before and after administration. And I'd also like for you to look at on this page that I have this aimed on right now about observations to make during a seizure at the top of page 527. You see different observations to make, including whether the patient cries out or screams at the beginning of the seizure, whether movements are bilateral or symmetrical, is the patient incontinent, are they apneic, cyanotic. Those are observations that you need to make and be able to communicate with your team, communicate to the neurologist, so that they can help decide what's the best therapy as far as medication-wise for this patient. Okay, after a seizure, there's a post-itical period where the patient is going to be drowsy, confused, and just wants to sleep. And they should be allowed to sleep and rest after the seizure. You do need to do neurological checks on the patient, including vital signs, orient the patient, see if they can answer basic neurocheck questions as to time and place, who they are, where they are, something like who's the President of the United States, things like that. Okay, as far as safety, I mentioned that it's very important as far as studying for your NCLEX to really read through the sections in your chapter about maintaining patient safety during a seizure. So if you are, let's say that we are sitting in a classroom and someone in your classroom has a seizure, you need to make sure and move the furniture out of the way so that they can't hit their head or hurt themselves on a piece of furniture adjacent to where they are. If there is a towel, small pillow, jacket, something like that, that can be put underneath their head to keep them from injuring their head. Also, try and turn them on their side as best as possible to keep them from aspirating. Getting people out of the way so that they're not being watched while they're having a seizure. Gathering as much information as you can about what is going on during the seizure and behaviors that you're seeing that we just discussed. Also, the patient is going to have triggers for their seizure sometimes. So it may be bright lights, it may be photosensitive, maybe certain electrolyte imbalances, or like I said, lack of sleep, being overtired can put someone at risk for a seizure, and that can put them into the status epilepticus that we just talked about. So when you think status epilepticus, and who's at risk, think of someone like yourself. Think of someone who is a student, someone who's studying a lot, trying to work, taking care of the family, doesn't have a lot of extra time, so they may not be taking their medications as they should. That is very, very important for patient teaching. Also, they may not be drinking enough water or eating enough nutrients and getting enough rest. Observe the patient for restlessness. That could be a trigger that you know a seizure is going to happen, or those auditory or visual auras that we talked about. And if you're in the hospital setting, as we mentioned, getting the patient on their side, preventing aspiration, placing oxygen on the patient, and also a very good thing to do is checking their blood sugar after the seizure, just to make sure that they don't have low blood sugar, and that's the reason why they're having a seizure. Also wanted to mention, your book talks about grief for someone that has epilepsy and limitations. They really are able to carry on with their job and do whatever someone who does not have epilepsy does. They just have to, as I mentioned time and again about the regimen of taking their medications on time and regularly and having their prescriptions. They may not drive for a year typically. after the seizure. So they need to be seizure-free for a year prior to being able to drive. And avoiding triggers, making sure to get adequate rest, and maintaining a healthy lifestyle is very important for them. So that's the first part of chapter 23, and I will see you for the second part. Thank you very much.